We use a definition that was developed by the National Institute of Neurological Diseases and Stroke. It says that the patient has delusions and hallucinations. They have to have had them for at least a month. They have to have started after the onset of Parkinson's disease, and there can't be any other cause, like delirium, for example, or some other cause of psychosis. We are trying to increase the awareness of psychosis in Parkinson's disease. There has been movement in terms of the development of new therapeutics for psychosis in Parkinson's disease. So this is a major problem for patients, and we want clinicians to be more aware of it, and we want clinicians to be more aware of emerging therapeutic alternatives. About 50% of patients with Parkinson's disease will eventually develop some psychotic phenomenon, either delusions or hallucinations. One of the major impacts of psychosis of Parkinson's disease is on the caregiver, and I think it's very important that we find solutions for patients that will benefit the caregiver also. By reducing the behavioral disturbances that patients with Parkinson's disease exhibit, the burden on the caregiver is substantially reduced. So what we're trying to do is to get better control of the behavior so that there's not such a demand on the caregiver. We know that there's emerging biology of the psychosis of Parkinson's disease. We know, for example, that people who have cognitive impairment are more likely to have psychosis and delusions and hallucinations than people who don't have cognitive impairment. We know that people who have eye disease or ear disease may be more likely to develop visual or auditory hallucinations. We know that the medication seems to have a permissive effect. It can occur without medication, but it's more likely after the medication has begun. So it seems like it's a constellation of factors that results in a brain ecology that promotes psychosis of Parkinson's disease. The Parkinson's disease is treated primarily with agents that worsen psychosis, and the psychosis is treated with agents that primarily worsen Parkinson's disease. So these are antagonistic goals, and it's why the development of new therapeutics has emerged as a way to respond to major unmet needs. Among the therapeutic agents that are emerging, there's a drug called pimavanserin that will eventually go to the FDA probably later this year and has had a very positive clinical trial for the treatment of Parkinson's disease psychosis. Currently, there's no FDA-approved medication for the psychosis of Parkinson's disease, so if we have a medication which is approved and is efficacious, then that opens the doorway to better treatment for patients with Parkinson's disease and psychotic phenomena. The adverse event profile of pimavanserin includes falls, for example, we're seeing in that group. The safety profile was very acceptable in terms of elderly patients. It had a beneficial effect on sleep. That was one of the things that we were encouraged by. So the balance between potential side effects and potential benefits was definitely in favor of benefit. The neuropsychiatry of Parkinson's disease and of Alzheimer's disease and other neurodegenerative diseases has been difficult to understand. It's difficult to get down to the neurobiology that would direct a drug development program. But in the last few years, we've seen substantial progress in this in terms of treating apathy and depression and psychosis and agitation in neurological disorders, and this is one part of the story of emerging therapeutics. The next step is to make sure that the FDA is comfortable with the data package that's submitted, that they approve the medication, that we get it into the hands of practitioners, and eventually improve the care of patients. That's our goal.